my topic now is to talk about ResMed telehealth service and solutions and what we found on the service side, how we can improve outcomes in patients with sleep disorder breathing. As Ramon said, we need to show our disclosures, which is also interesting because most people don't show their disclosures properly. I think on average it's below 2 seconds that people show their disclosures. But also, by the way, there has never been evidence that showing disclosures has anything to do with the validity of the presentation. But also, kind of a big data research is starting to look now at all of that. And there's now an analysis that at least 50% of the physicians don't show their proper disclosures when you compare their papers with what's available on the web or other information on who they work with. Yeah. And the latest trend is that now physicians start tweeting about medical products, and now there's a discussion that if physicians tweet about medical products, they should show their disclosures on their tweet. So we're going to face a couple of challenges also with big data and how we deal with it with our modern technology. I wanted to just summarize 2 different terminologies because I think you can talk about telehealth, ehealth, mhealth, whatever. There's many names around it. I think what's different is ehealth was introduced quite early. There's this very nice article from 2005, which is on the web because it's in the Journal of Medical Internet Research, that explained already over a decade ago what encompasses as ehealth, which was mainly, at that time, the use of telemedicine and the use of computers. Very worthwhile reading this paper, because already 12 years ago it showed, I think, the way and what it all encompasses, what we're doing. I think nowadays what comes in addition to it is mhealth, mobile health, okay? Everybody's using his smartphone here while either taking a picture, writing a text, and whatever. We have all sorts of information, not just health information, but also lifestyle information and other information. And one of my favorite analyses lately is that you can use Twitter information and the change of your tweets to at least indicate a higher risk of depression by the way you change your tweets. And I think, for example, also being a pulmonologist, I think you could easier see that somebody has a worsening of his asthma by changing his tweets than by looking at respiratory rate. So that's the interesting thing of mobile health, that we're combining everyday information together with completely new data sets. So what's available in terms of telehealth? I think there's 2 things that I want to talk about. One is AirView, which is a cloud-based patient management system. And the other one is myAir, which is a patient engagement system. This is kind of like eHealth, and this is kind of like mHealth, okay? In addition, there's in the US a system which allows a patient population management, which we don't have in Europe, which is called uSleep, and we're going to see some publications coming up from that. Then we have the traditional software solution for downloading devices also on the web. But the things I want to talk about is the eHealth solution, which is called AirView, which is a database of your patient device data. And the other solution is the patient feedback loop. So the patient engagement system, mHealth, uses either tablets or smartphones where the patient gets a feedback from his therapy, but not just information management, but also he gets education. If he's got problems, for example, with leak, he can look at a video that explains better mask fit, as an example. Yeah, so it's not just one-sided information, but it's also a feedback system, a dynamic feedback system, okay? And as you can see, there's also a Twitter symbol, and we know that a lot of patients use it then to tweet that they had a perfect score on their night, which shows they engage with their therapy. But the question is that helpful? One thing that I wanted to mention, because Ramon did a great job on that, but whenever we talk about big data, information privacy is very important. For example, the data I'm going to show are coming from Germany. And in Germany, we're working with big data now for 10 years, and we learned that we are allowed to use in Germany anonymized data sets for research. So whenever there is a database and we export an anonymized data set, we don't need IRB approval. IRBs won't even look at it because they say it's German law that you can take this for research purposes. We even asked, because IRBs told us that a couple of data privacy lawyers who also said you can use that anonymized database for research, but that's not yet understood. For example, when we submit papers, people always say, where's your IRB clearance? But for example, a country like Germany, you won't get IRB clearance because you don't need it. But that's very important when we talk about research in that field, about the privacy, and that is currently a national thing in most of the countries. Then the other thing I wanted to briefly mention is that big data is often being referred to not because it's big data, but because we're trying to make an analysis a little bit more sexy. Okay, so we're taking this new data set, and so it's more about the analytics than the data set itself. So big data is being used for really big data, but also for certain analysis. So we know there's 5 V's of big data. One is very important for medicine, which is veracity, or the certainty or uncertainty of the data. For example, if you do research on, for example, your fitness tracker, I mean, we know that a couple of people do put their fitness tracker on their dog, because with that they get more steps and they get a better score, So we actually don't know, who uses the fitness tracker himself, his Fitbit or whatever, and who puts it on his dog or cat, We just know that we get steps, yeah. And so that's something that's very interesting, especially with machine learning. I like that machine learning example, that it's hard, for example, to compare a blueberry muffin with a chihuahua if you're a machine learning computer. So I think uncertainty of the data is something that we have to work with. The other, the V number 5 is value. We can compute any kind of analysis nowadays. The question is, what's then the value for healthcare? And we know that the biggest telehealth system right now globally is the ResMed AirView system, and Ramon just showed it. There's over 1 billion nights now in the system. So there is lots of information, and the question is, what can we do with it? What's also important, currently our research teams are completely in a wrong setup for doing these analysis, because we're mainly clinicians, and we need completely different skills in our research team, and I can show you that's the ResMed Big Data team. And I can tell you, that's the first team that we established, and I was the only physician in there. Yeah, the rest of them are all data scientists. Yeah, and so we're working in different setups, and the more we work with big data, the more people like Ramon, who's not a physician but a researcher, a scientist, will work with us. I think it's going to lead to more collaboration. Yeah, so what I'm trying to focus on is now big data mining in healthcare databases as being big data. And we started with that in 2010 when we analyzed roughly 5,000 devices which were returned for a technical reason. And we were interested because the biggest compliance study in Europe is still from the last century, and it's got 1,200 patients in, and we wanted to know what's the normal compliance. So we published roughly 4,000 patients and showed their usage that they had with the device. And those devices were just randomly coming back for a technical reason. And that fueled our interest to look more into big data and how we could do that. And ResMed in Germany has its own healthcare, and the healthcare has a normal system to run their business. And when they updated it, we tried to find a way to use a database that's being used for business for research. And we created a group, and I'm part of that group with Michael Arzt, Andrea Gramos, our statistician, Ingo Vize, Peter Young, Helmut Teschler, and Jochen Ficker. We're kind of like a steering group who looks at the data and analyzes it. Because it's an anonymized database, we're able to do that. And so the first thing that we did, we looked at all patients over a 5-year period who started therapy. And so what's very important when you look at big data, look at the consort diagram, or the study flow, it's more, the data flow. Because by just changing in and exclusion criteria, you can very easily change your results. So what's very important is, if you read a paper about big data, look at how many patients were included. The goal of big data analysis is to exclude as few patients as possible. And so we came up with 100,000 patients, which we think is the biggest analysis yet of compliance. And what we could come up, we could show that that's the risk for therapy termination in the first year. And you can see that females have a much higher risk compared to males. That younger patients have a much higher risk, and older patients have a much higher risk. Also, what German politicians don't like to see is that private patients have a much lower likelihood of stopping therapy because they might get different care. And also, interestingly, that we were surprised that bilevel and ASV patients had a lower risk of therapy termination in 100,000 patients. We think that's quite robust data. And here's, for example, the gender difference. And I think data like that helps us then to tailor interventions to groups at risk. What's also interesting is that at least in our analysis here throughout 1 year, which is not the normal one that we see normally in publications, because normally publications are being driven by centers who see patients for a regular follow-up, for example, after 3 months or after 6 months. Yeah, a health care company like ResMed in Germany gets devices back whenever the patient quits, not when there is a certain time of follow-up. And this shows here that there's rather a linear decrease in compliance over the first year, compared to the medical publications who are driven by regular follow-ups and with that have, I think, different curves. So it's something that's of interest. What we then looked is, when you take an eHealth system and you use it in your healthcare, and you go from a reactive service to a proactive service, if a patient gets put on a CPAP, doesn't matter where in Europe, he has to experience problems and call his center, and then he gets a reactive service. That's the way we've done sleep medicine the last 20 years. So telehealth, eHealth enables us to kind of recognize that the patient is experiencing problems while we don't see him in clinic. And we can then communicate with the patient and try to fix the problem. And those are not randomized trials, but those are comparisons coming out of this big data. We just published that in a German somnology journal. It's open access, so if you want to access it. And we could show that with this proactive care model, the therapy termination rate in the first year was halved. Although eHealth rather shows you when the patient is struggling, so you could think that you got to have more patients dropping off because you see it earlier on. So we see there a 50% reduction in therapy termination the first year. And the other analysis that we've done is then if we take, in addition to eHealth, mhealth, a patient engagement system, that's something that we just submitted for publication. So we took the first 500 patients who got this patient engagement system and compared them with 500 patients who are having the proactive care. At the time when proactive care started, the mhealth solution was not available. And also the patients who signed up already for AirView 2 or 3 years ago had to have somewhat a tendency to liking modern technology, like the ones that use now myAir. So that's why we think there's always a potential bias, but we think the bias is potentially much lower because both groups had to like technology. And what is interesting, so we're comparing 500 patients usual care with 500 patients patient engagement, but usual care here encompasses proactive care, so patients who are managed with telehealth, with eHealth. And you see those patients are younger because they have to somewhat be prone to technology. We match those two groups for devices, for masks, for pressures, for insurance, for anything that we could do. But you can see that those are the 180 days results, that low usage, that's the usual care, the light gray bars, is more common in the usual care. And in the patient engagement group, we have higher usage. So we get better compliance even if we add this feedback loop. So telehealth itself improves outcomes because probably we fix problems when we don't see him, and so the patient stays on therapy. But then if we take the patient in the loop, we engage him and we educate him. And there's one interesting result that I want to show you, and that is that those patients who have the patient engagement have less leak, okay? So they get more feedback on mask fitting, they get less leak, and with less leak, it's at least associated with better compliance. So there is also some biologic reasoning in our data set why this might occur. Yeah, that it's not just about telling the patient in the morning, you've done great, you get 90 points, but it's also in giving the patient the feedback that you should do a little bit better with your mask, look for your mask seal, look for your mask fitting, and that seems to work out in terms of better mask fit with less leakage, and that's associated with significant better usage. By the way, the interesting thing is the better usage is mainly driven by using it more days. They take less days off therapy in the first 180 days. It will be interesting, that's first results from the first half year, which is in Germany most decisive for, you have to have 6 months, and then it's being decided if you go on long-term therapy, then year after year. That's why we took 6 months. It will be interesting, it will continue the trend, or if it's just an early effect, but at least for the initial crucial phase, we can see with the addition of the system, we can improve compliance and we can reduce leakage. And that's just the first step, and I think that's a projection of mobile health in 2024. I'm glad that my kids are old enough that we don't need to have wearable sensors in diapers, but they're talking about sensors in your bathroom to meet your to measure your glucose, for example. We don't even see yet, what's the potential of mobile health. There's skin patches coming for everything, skin patches for ECG, skin patches for temperature. So the information that we're getting is more and more. With that, we can phenotype patients better, but most important, we can tailor interventions for our patients, and we can create feedback loops to patients to engage them with the therapy. So I hope I was able to give you an insight into what we've done when we take the technology and include it in a care management system, and with that, trying to improve outcomes for patients treated with PAP. Thank you very much.